Well, thank you for having me today. What a gorgeous day outside. I appreciate all the faculty and staff organizing this wonderful symposium. I'm excited to share the proposal that we submitted and got selected for the pilot grant, which is in line of long years of our research team's work on the Radon initiative, focusing on mothers of the infants population. Okay. Not this one. Here. I'm not going to bore you with all the information about how radon is bad and all that, but I wanted to summarize a little bit of our efforts in the past 7-8 years, including a lot of the team members, researchers, and partners, to better educate the public about the dangers of radon, and then how we can motivate them to actually work on testing their houses. So my academic home is in communication, so I'm a part of a communication researcher in this large group of individuals who are really motivated to solve this radon issue, particularly in North Dakota. One of the major initiatives that we've been doing so far is to use the mobile app on your smartphone to educate the public and then motivate their behavioral changes. What we have learned so far in many years of our efforts is that traditional educations, like a typically EPA or other organizations tend to do, are not really effective. However, the Radon app that we developed as a part of our team efforts is very effective in educating the public. They are more aware of what radon is and then what are the harms that it can cause you from the prolonged exposure. And then even after that, it is very effective tool to encourage people to request radon test kits, which is the first step of the multiple behavioral chains that we've seen. However, we actually have been seeing a new problem or a more worthy problem to solve, which our focus is here, that only 20%, and that's actually almost a maximum number based on the literatures that we've been seeing, is a very small number of people actually utilize the test kit that they requested. So it's really a wasted and underutilized opportunity to go right into how we can focus on actually changing their behaviors. And that's not a new question. Psychologists and social scientists have been exploring that question many, many years now, and it's a difficult problem to solve. We realize that in this particular behavioral chain is that having individuals required to get the test kits is a barrier, and it's an easy barrier to remove. And this is a typical process local and state health departments do. They have their public and local community members request a free radon test kit to receive it. But we know that only 2 out of 10 will use it. We focus on not just the general public this time, but we wanted to focus on a highly specific target audience, which is the mothers of the infants. We conceptualize this group of people who are childbearing age, likely a little lower end of the age group, who are more tech savvier than older generation, who are very familiar with the digital technology, mobile apps, and et cetera. And then they are, conceptually speaking, they're a very highly motivated group of individuals to create a safe and healthy environment for their family. So they are willing to change their behaviors if it makes it healthier for their babies and themselves. So we realize that this is an opportunity for us to test out some of the things that we learned from the previous efforts to remove the barriers and hopefully see a higher utilization rates. So that's a little bit of background information. Our purpose for this proposed pilot grant award is to test the feasibility of the Radon app that we developed and tested in a multiple empirical settings to see if whether it actually does similar functions in this particular group of individuals that we feel like is a great opportunity. So we wanted to test 2 aims. First aim focuses really on the cognitive side of the outcomes that we think that's a precedent or antecedent of the behavioral changes that we ultimately want to see. So changes in radon knowledge, whether they know more and have accurate information about radon, and then efficacy beliefs. Efficacy is more soft variables, if you say. Self-efficacy is that basically that we feel like we can do this. And then when you say you're testing your house, some people, when you talk to them, they get overwhelmed. Is it something that I can do? Is it cost a lot of money? Things are the common questions that we often faced. But then it's actually pretty simple using those test kits. So we want to see if whether it increased their efficacy. Response efficacy is also another dimension that testing their house is an effective measure to prevent themselves from the radon exposure, which it is the case. So we wanted to see those cognitive changes as well as their intention and behaviors to share this information about radon with the others. Second aim is the key outcome that we are really interested in measuring, which is the test kit utilization rates. And then we work closely with the Alpha Energy Lab, which produces those test kits that we utilize, and they send us the actual results report. So it's not based on self-reports, but then it's on actual behavioral outcomes that we can track and measure. So it's a very simple pilot trial that we wanted to do with a group of mothers who will be attending well child care visits in Center for Family Medicine in Bismarck and Minot locations. At the time of their arrival, which we labeled it as a T1, they would be invited to do the participate in the study. It will be a short online survey to measure the base cognitive outcomes. And then they will given instruction to install the Radon app, very simple as you would do for any other apps. You would go to App Store, Google Play, search the name, download it, and then they will be given as a gift, in addition to some monetary incentives, they will be receiving those free Radon test kits. So that there we remove that request portion of the barrier. And then for about 2 months, in about 2 months, they will receive an email message from us where they're invited to the follow-up survey, which then we will be able to check their changes in their cognitive outcomes since the 2 months ago. We labeled them as T2, and we'll give them an instructions that just use the app as you would normally do for other apps so that it has that external validity in there. And then we'll continue to track their usage rates, which can come probably within that 4 months window. We label that as T3. It can come much later, but then we will continue to track those utilization rates so that we have information about whether they actually used it. If they used it, how high their levels were. So those are the information that we will be able to collect. We're hoping that we would see the increase in knowledge, efficacy, beliefs, and sharing behaviors, obviously, through the changes in those 2 time points of the survey. We've seen very promising results from other populations, but then this, again, is a very specialized population that we're very excited to try out. So we're hoping to see that positive changes. 20% is the benchmark number that we're using as based on the literatures that we've been looking at, that we're hoping that at least 20% will utilize the test kit that they freely received. And then by continuing to use the app, they would be informed about how easy it is and then how effective it is to use those test kits to protect themselves and their family. So then we want to demonstrate, obviously, as the feasibility of this app-based intervention that we have been able to test it out in a couple different settings and then incorporate that into the clinical setting. So some of the things that we're very excited about is continuing to test out this mobile app that we have been able to utilize, that we have demonstrated the success in the knowledge increase and then app request rates, but not the utilization rates. And then we're also very excited about bringing that into the clinical routine care setting where we can directly deliver the test kit so we know for sure that they received it without requesting it. There was no accident in the delivery, that there failed the delivery, and et cetera. So again, kind of demonstrating the feasibility, I think it can go a little way further and trying out, hopefully incorporate into some clinical settings and other populations who may be more motivated in terms of the health behavior change in the general public. So these are the resources or the references that I cited. Thank you again for TRANSCEND and then all the faculty and staff members involved. Thank you, Dr. Schmitz, and then Center for Family Medicine, who are willing to be a partner to this project. And then TriDet Interactive Media, it has been a partner for us many years to develop this, starting from very clunky version of the Veda app until now. And the Alpha Energy Lab also has been a great partner for us to share those testing results so that we have those actual behavioral measures. Okay, that's all I have. Happy to take any questions. Thank you.
Thank you. It was a really nice talk. Do you plan to stratify the subjects by how many children they have, or I guess the number of household individuals?
For sure. We will measure those as part of the base survey. We don't even have the control group in this setting because this is our first attempt to be in a clinical setting. So we're not randomizing or assigning them to the conditions, but we will certainly measure those outcomes and then needed control for it or stratify it when we analyze the data.
Okay, well, without questions, I'll ask one of my own, or at least a clarification. So it sounds like with the women you're enrolling in this, everyone who's enrolled will get a test kit. Is that like physically at the enrollment?
Mm-hmm. Yep.
So there's like, okay, there's
no the plan. Yep.
No problems of like them shipping it and
right.
not getting
Yeah,
it. Okay, so of your sample size, you can directly measure how many actually use it.
Exactly.
Okay, great.
And we will know there, when we give out the test kit, we will have the barcode number to attach to those participants, so we know for sure. Sometimes it's usually mothers coming to the routine care, and then fathers usually test it. So when you see the names of the test results reports that we get from the labs, same last name, but different names. But it's one per household, basically, when you're giving out. Yep.
Okay. All right, with that, thanks again, Dr. Kim.
Thank you.